to this session of EyeShala. So we'll be going through the basics of a number of basic investigations in retinal sciences, and I hope this will really benefit all our postgraduates and fellows who are here. So without further ado, it's my pleasure to invite Dr. Unnikrishnan Nair to speak on interpretation of octa. Over to you, Uni.
Okay. Thank you. Do we have any postgraduates or one? So this is entirely dedicated to you now, sir. Slides are not moving. Okay. So just to start a few slides on what we mean by octa, we're just talking about repetitive scans at one particular area is a basic concept. Repetitive scans at one particular area. And what this does is there are four basic principles of octa: speckle, volume, decorrelation, and emphase. What does that mean? Speckle is any effect produced by a scan that is interpreted. Decorrelation is the most important thing in octa, is a difference between two speckles. That is, when you have one reflected image and the second reflected image, the difference is called a decorrelation. And the volume and the emphase are the imaging methods. The volume is that the octa produces not a single, it's depth resolved. You have multiple layers in which you can interpret, and the emphase is the way of looking at the scan. In a regular OCT, it is sideways. The octa is always from the top. You're looking from the top like you do. And so these are the four basic tenets. So I just want to tell you that this is a basic principle. When you have two scans and something changes, the assumption, the only moving thing inside the eye is RBCs when everything else is kept. And that is tracing the path of the RBC is a de facto way of identifying blood vessels. So the principle is that when the RBC moves, the movement is detected and you see the small red line that the movement is picked up. The problem is that if the RBC is too slow, there will be no difference between the speckle. The machine doesn't produce and you don't get, and this is called an interscan time. And if it's too fast, the same thing happens. Between the two speckles, in that threshold, nothing is caught. So this is the basic principle of OCTA. And the clinical applications, just we have to say that this is not dye-less angiography. That's the first thing we just have to get into. There are whole new brilliant concepts of diagnosis. So today we'll either learn something truly revolutionary or we'll learn how to talk like a retinal surgeon. So the AMD diagnosis, the first important thing is how to capture the image. I'm not going to these things because we're talking about interpretation, but I just want to show you the same image based on the scan depth, the scan thickness. You can interpret a CNVM in different shapes and sizes, which means that when you want to reproduce something, you should know the original set or the original slab depth and all those things to know how big or how small a CNVM is. This is another example. Different slab sections, different area, the CNVM looks different in different sections. So when we go to AMD, I like to write it in the opposite way: type 1, type 2, type 3, and the yellow line is the RP. It's a very simple way of understanding where the type 1 is, where the type 2 is, and what is a type 3. And when we look at a lesion, these are the things we look at: caliber of the vessel, compactness, whether it's filamentous or not, the pattern of the vessel, the gaps between the vessel. We'll just go through these in detail later. So we'll first look at type 2. So if you look at a type 2, it's like you see in an FA. It's very compact, very lacy, lots of small vessels, hardly any gap between the vessels. It's a very compact lesion. And these are some more examples where you see in the structure flow, you see over here, you can see that there is a yellowish dots which indicate movement of the RBCs, which is above the RP line. So that's how you know it has breached the RP line. So as I said, this is how you make out a breach. If you look at this picture, you see a pattern above the RPE, which tells you that the RP has been breached by the vasculature, and therefore this is a type 2. Type 1 is below, type 2 is above. Again, here you can see that with the RP being represented, there is the flow characteristics are seen above the RP. Therefore, again, this is a type 2. just to show a few brilliant uses of the OCTA. You can see the structure of the vascular net much better than in any angiographic process where pooling and leakage obscure the margins. Here you see the blood vessel edges very careful. Just look at this patient where by knowledge we know that this is, it looks like a late phase indicating a CNVM on angiography, and that's the size of the angiography. But when you look at this particular picture, you understand that the size is not what you saw. It is a oriented lesion, a horizontal, even slanted lesion with three major components going on either sides, and you see the vasculature better. So in the type 2, the vessel caliber is thinner. It is a very dense lesion. The filamentous type vessels are uncommon. It has a lacy pattern. The gaps between the vessels are less. Perilesional halo, I'll come to that later, is less. The flow characteristics show breach, and the inability to image by obscuration is comparatively less because it's already come up above the RPE. So you image it better. So the type 1 lesions are very different from what we saw. You can see immediately from the picture, you can see that the fine nature, the fibrillary nature is lost. Fibrillary becomes filamentous. You see larger vessels, more defined, more gaps between the vessels. This is a very beautiful picture of a type 1. Large vessels going in different directions, gaps between the vessels, and the very fineness of the constitution is lost because it's of this. And just one word on perilesional. Perilesional is very important because it's a dark area around the lesion. Why does it happen? Because the CNVM is stealing from the chorea capillaris around it. So it doesn't image well around it. The chorea capillaris around it is dark. So again, I'm just skipping that, but let's look at this. The vessel caliber is thicker. The compactness is looser. There are gaps between it. It's a filamentous pattern. A perilesional halo is seen commonly. The flow characteristics show that it's under the RPE. Okay, the structure flow doesn't go above it, and there is often inability to observe it because there are hemorrhages, there's edema, there's fibrin, so all these things. So these are some of the morphological characteristics of AMD. You have a lacy pattern. Sometimes you get a medusa head where the feeder is in the center and goes to all sides. The C-fan is when the feeder is on one side and the vessel grows to the other side. And there's other components like the fishnet, which is extremely dense but has larger vessels. This is a worse prognosis type. The dark halo sign, as I said, is because the lesion steals from the chorea capillaris around the lesion. And you can see it over here. Here you see the lesion, but you see this dark rim going around it, and that is where the steal happens. So look at this picture. I like this picture. Just look at this picture. You can see two things. Inside is what a type 1 looks like, filamentous spaces. Outside is what the type 2 looks like. So if you keep this picture in your mind, you'll always try to correlate and understand what a type 1 and a type 2 looks like on an octa. So type 3, I am not going to spend time on type 3. Why? Because you see all these features you get on angiography, and this is what you get on octa. Sometimes you get a retinal spot because of the thing, but the characteristics are extremely hidden. For an octa is not the ideal investigation for a type 3. Now let's go to PCV. PCV, we know how it looks. And when the octa came, it was slightly disappointing because the flow characteristics weren't perfect in octa. So I'll just show you. This is what a PCV looks like. The ICG would give much better. Here you can see a fibrillary network, which is a BVN, and a few dots on the center, which are polyps. This is a brilliant representation. You never usually get it this well. Why? Because usually PCV associated with high PEDs, and whenever there is a tremendous disruption of when you get height in your PEDs, the imaging on octa goes bad. So these are an example. You can see here on this picture over here, you can see the BVN, and at the edges you can see nodular outpouchings. Again, if you look at the OCT, you know it's not very high, and that's why you're getting these imaging well. The minute it goes high, you don't get the proper segmentation lines. So these are all comparatively well things, and these are things. They're called divided into circles, the polyps, circles, clusters, spots, and undetected. Mostly it is, this is what we get. We don't detect it well. But the main thing is that OCTA is great to diagnose BVNs and bad to pick up polyps in PCV. So you get indirect evidence of a PCV on OCTA. Sometimes you don't get the direct evidence. And this is an example of it. So MACTEL is the next condition. So when the main use of MACTEL in MACTEL is to diagnose when a non-proliferative stage 1, 2, 3, 4 becomes stage 5. That is the main use of Octa in MACTEL. And there are a lot of features, and let's go to the features. You have abnormality of the vessels in the temporal periphery, and then you have a vertical change where you see these abnormalities in different layers. You are not supposed to see any vasculature in the avascular layer, and and if you see this vasculature in the avascular layer, that's a CNVM. So it's very simple. It's a CNVM. Therefore, it has become proliferative. So just look at this picture. So let's look sequentially. The superficial vascular plexus, the intermediate vascular plexus, where you look at the temporal side over here and you see some vasculature, some change in flow, some abnormal dragging of the vessels. Then it becomes more in the DVP. But in the avascular zone, you don't see anything much, which means that this is a non-proliferative. And now let's go to the next one. The superior, the venous plexus, the intermediate, there's dragging changes. But in the avascular zone where you're not supposed to see anything, you see a lesion, a vascular lesion, which is a CNVM. And this is how you differentiate non-proliferative from proliferative MACTEL. Another use in MACTEL is that when there is a CNVM and you do an FFA, you get a lot of blooming. You don't know whether this blooming or leakage is because of the MACTEL or because of the CNVM. But look at this. The OCTA picks out this anatomical component of the CNVM and tells you that it has gone beyond a plain non-proliferative. It is not the blooming because of the it is the blooming and the leakage because of the CNVM. Okay. So just look at these features. Non-proliferative, you see all these features, and the proliferative, you see true flow in the avascular layer. So this is how you differentiate a non-proliferative and a proliferative, and all the features put together essentially. The other uses in AMD are this condition. It is called a non-exudative CNVM. You see a bumpiness over there, which we also call the double layer sign, but no signs of CME or SRF. It's a CNVM which is not exuding. It's a new concept. Why? It's a precursor lesion. They convert 22% to 50% convert to in the next 24 months. So when you do an Octa, this is an Octa diagnosis. When you do an Octa, you see a vascular net, but no ill effects of the vascular net. And you see it very clearly over here. And this is the thing. There are two types of non-exudative CNVMs. One is because of angiogenesis. They are subclinical. They are they're going to become a CNVM later. And the next is because of arteriogen. They are the truly quiescent ones that are sitting there, not causing any harm. They are quiescent non-exudative CNVMs. I'm not going to detail, but there are two types essentially. And in the picture you see one has a lacy pattern, it's not CNVM yet, and the other has a more filamentous pattern with gaps. So angiogenesis versus arteriogenesis in the very cellular level. This is a cellular tissue level differentiation. And why does this happen? It happens because of recapitulation. Why? A non-exudative CNVM or a CNVM after treatment that remains are actually beneficial to the RPE. They provide alternate nourishment, alternate circulation to prevent atrophy happening. So that is why in the newer and newer concepts lead us not to aggressively treat CNVMs till the last drop of SRF has gone away. You may observe or tolerate is the right word, a little bit of SRF. So these are, and this is the protective. There's no SRF, no CME, but you can see there's a large vascular net on Octa exactly underneath the fovea at a large area, and that is the CNVM or the residue of the CNVM providing circulation to the RPE. It's a protective effect. So I will just probably stop with this. Recurrence of CNVMs. How do you know when a CNVM is coming back after treatment? It's a beautiful picture to show you. You see the edges, you see small anastomotic things going along the edge. You see small vessels in between the large filamentous vessels. And this is how Octa tells you that a CNVM is recurring. You see this picture over here. You see the anastomotic channel in the edge, and you see it happening. So in this you see anastomotic. This is the older part of the CNVM which is quiet, And this is a newer part of the recurrence which is active nowadays. And this is how it happens. The last part of the talk, I'm limiting to AMD, is identifying scars. So in a scar, what we said about the fibrillary nature, dead tree, there's a tree with no branches. This is the appearance of that. And this tells you whatever we talked before, there are no small branches, there's no peripheral lesions, it's just like film, like a dead tree. And the second point is called skeletonization. When the CNVM breaks into small and it looks like bones of a hand, that is when you see the flow is fragmented in the CNVM, and that is a sign of regression of the CNVM or skeletonization. Okay, you can see it well in this picture. A fragmented vasculature. So again, when the thing is improving or it is down-regulating or going away, it becomes less compact, more filamentous, a dead tree pattern, gaps are more, and when it is up-regulating or recurring, it becomes more fibrillary, more compact, peripheral changes are more, the vascular density is more. Again, look at this as my parting slide, the same picture. Inside is how a regressing looks like, outside is how a progressing looks like. So with this picture, if you keep it in your mind, you can differentiate a type 1 and a type 2 and a regressing and a progressing. And I think I'm going to stop here. And this was the just an interpretation in AMD. Thank you.
Thank you, Uni. A fantastic talk as usual. I guess everybody picked up a lot of pearls on Okta interpretation. So thank you very much, and hope to see you next too. Yeah. So yeah. No, so it's my pleasure now to invite Dr. Balamurugan to speak to us on evaluation of a patient with uveitis. Dr. Balamurugan is the head of uvea service at Arvind Pondicherry.
A pleasant good morning to one and all. After such a wonderful talk on OCTA, my talk on evaluation of patients with uveitis will be very, very basic, or rather ultra basic. So uveitis, I call it as mother of surprises. It's surprise not only for you, not only for we, it's for everyone. It's a mother of all surprises. So the basics in handling uveitis starts with first talking to the patients. See, post-COVID, we have all become very negligent in talking more to the patient, describing all the complaints, evaluating all the systemic associations that needs to be really, really looked into. So this was a wonderful article where I was fortunate to be the co-author, where it has been really captured that 75% of the diagnosis can be properly achieved if you do meticulous history taking. Underlined, it is meticulous. So it is a cornerstone in the management of uveitis. If you bypass this history taking and outsource to some other person, however you do meticulous investigation, treatment, you will end up in problem. So history is the cornerstone. So the rules in uveitis practice, my teacher has taught me that's meticulous history taking is prerequisite, not only for diagnosis and also for correct treatment. The second rule is, again, don't forget rule number 1. So it may look something you have heard somewhere else. So please remember, history is very, very important. So look at this case. This was a 42-year-old lady who presented with keratouveitis. If you can see some granulomatous keratic precipitates as well as. And the patient was started on topical steroids. So the patient came back after 2 days for the reading of the Mantoux test, and look how it flared up. So what was the history that was overlooked? That history of native treatment. So it's a violent case of Aspergillus fumigatus, which we were able to identify and publish as well. The second point in the evaluation of uveitis is evaluate and examine each and every part of the eye. So before correlating the symptoms, so we need to be very, very careful that we examine the eye properly. A lot of people forget that there are 2 eyes and the eye is part of a body system. So you can't say that I did not do IO, I missed the peripheral AR, and nobody will excuse us. So if the fundus is not viewable, B-scan is always there. So my impressive teacher has taught me that if you do only 90-day examination, you are going to miss a lot of the parts of inside of the eye, which you should not be doing it. The single most take-home message is, whenever you see uveitis, don't forget to do IO. because I see a lot of students just seeing only the slit lamp, not only bothering to make the patient lie down and do IO. And now I see the next generation postgraduates doing IO in the sitting posture. I don't know how they will be able to see the pars plana. It is really, really impossible unless you are a super duper IO person. So make sure that you meticulously do an indirect ophthalmoscopy. Don't miss certain peripheral findings. And the third important point is reach an anatomical clinical diagnosis. This is not something fancy. See, it's not a big deal. You can easily reach anterior, intermediate, posterior, or pan uveitis based on what all elementary stuff you all know of it. So based on that, outline a list of differential diagnosis and then proceed with the definitive plan. So the descriptors Sun has given, onset, duration, course. This was Sun 1. And if you happen to see, the Sun 2 has also come. Each of the 25 uveitic entities, they have defined what to use as descriptors of uveitis. So the most important is chronic and acute. Chronic is more than 3 months and acute is of a lesser duration. What is important is, in uveitis there is no terminology called subacute. So please remember, it is either acute or chronic, or in between there is recurrent. Okay, and this descriptors of uveitis as granulomatous and non-granulomatous is very, very elementary, which is easily overlooked. See, you don't say cataract as cataract. You describe as immature, mature, hypermature. Similarly, always whenever you see a KPs, keratic precipitates, qualify them as granulomatous or non-granulomatous. You can be wrong. There could be borderline, which we call as microgranulomatous. So you all know that the list of differentials is going to change as we see in the subsequent slides. And this is one important thing which you should always keep in mind, is we should be malleable. We should be shameless to change the diagnosis. And I say that I need to revisit the diagnosis each and every step. Uveitis is dynamic. The dynamicity of the clinician should match the dynamicity of the disease process. If we are not dynamic and not changing as per the change that is happening, we may end up wrong. Look at this illustration. Sometimes things are not the same as they look like. This was a patient who was present with defective vision of 1/60, and you see some funny looking macular choroidal lesions, and we did an FFA. If you carefully see, there was some peripheral vascular leak, and we did all the investigation. Mantle showed necrotic mantle, which was sort of pustule and all those big ulceration with raised ESR. So this necrotic mantle is seeing like a histopathological slide. No wonder we started on ATT along with oral steroids. What happened was, the inflammation recurred when the steroids were down tapered, and even the other eye got involved. And you can see a lot of hemorrhages around the vessels as well. The vision, which was 6/6 in the other eye, dropped to 3/60. And we again repeated FFA. As you see, there is an N large FAZ, and you could see a lot of peripheral vascular lesion as well. And now, looking at this early phase carefully, you can easily see the scattered track appearance, mid phase as well, and the late phase. So what do you see? There is an ocular ischemic syndrome. So I checked the blood pressure in the limbs. There was an absent radial pulse. And the BP upper limb, lower limb, there was a difference of 210/120. So even a basic examination of blood pressure checking can help you in reaching this wonderful diagnosis of severe Takayasu arteritis. So you see such severe uveitis, you are supposed to handle with a rheumatologist along with high-dose immunosuppressant, preferably a cyclophosphamide or an IV methylpred. That could have easily salvaged the patient. So don't be carried away only by the investigations. Just because we started ATT, don't be very arrogant in not revising the diagnosis. So when there is a lack of steroid response, there are multiple possibilities. What are they? The first one could be a possible infectious uveitis, straightforward. It could be an aggressive non-infectious etiology, again looks plausible. Fungal uveitis could be like one other possibility. It could be a metabolic masquerades, or even a straight masquerade like lymphomas, leukemias, or even an ocular ischemic syndrome, which could masquerade as uveitic entities. So keep all your options open. So lack of steroid response could be multidimensional. And the next important message is, be a clinician. So I am very fancied of uveitis because I need to be very, very clinical and take each of the investigations as a pinch of the salt. all the reports, including the histopathology, needs clinical correlation and need to be taken as a pinch of the salt. So before ordering the test, have a plan what to do. So without a plan, if you order all the tests, it will be a maze. So there is something called pre-test probability of the test. That depends on the population you are working in. So if you don't know what you are looking for, you may not find an answer or you may find a wrong one. So sometimes investigation is not at all required. When you are sure of the etiology, say a traumatic uveitis or a Fuchs uveitis, some people say low grade non-granulomatous. However, some investigations are meticulously mentioned not to be ordered. What are they? ELISA TB test. I see still people ordering. There is WHO has banned this test. Quantiferon TB Gold as a replacement for traditional MAN2. It's not a replacement. It's just a supplementary. Toxocara antibodies. It's not validated. You need to be a good clinician. And chest X-ray, if you order APU instead of PAVU, it could be a maze. You will not see the details. Serum titers for HSV, VZV, CMV by ELISA, again, the pre-test probability is very poor that you need not order all these useless investigations. And sometimes common sense is very, very important. Don't have to read a lot of articles to order investigations. If you see a patient with a worm in the anterior chamber, what test are you going to order? Nothing. You just take the patient to the OR, remove the worm and examine the worm under the microscope. The job is done. Don't do all fancy stuff at this position. Like what else you have to do? Order for a poor personal hygiene and do a health education and anti-helminthics to prevent the systemic infection as well. So when we do proper history taking, you can even get ideas to do PhD as well. So when I was a postgraduate, I used to work with my mentor, who used to get a lot of patients called anterior chamber granuloma as well as conjunctival granuloma. So we used to do all the MAN2 tests, all the investigation. Those days, these patients were given ATT also. Sometimes we, in a camp, we saw a lot of clustering of these patients and we asked that what history is relevant there. And the history relevant was taking bath in ponds. And this happened to be a river water granuloma, and we were able to identify a new worm that is causing ocular manifestation called Procerovarum varium, and this is a new entity called trematode-induced uveitis, which presented as granulomas. So meticulous history taking even helps you to reach PhD degree as well if you do a PCR from the granuloma and identify the organism. So sometimes on examination, we need to be very, very vigilant. You see an eye which is peripherally shallow, centrally deep, looking little funny. So we have to ask, why the central is also not deep? So what you are going to do at this juncture is order a UBM, look for cyclitic membrane. Why cyclitic membrane? The approach to handle this uveitic cataract is going to be entirely different. If cyclitic membrane is associated, you are going to remove this cataract surgery using a posterior approach, pars plana approach rather than an anterior approach. So UBM is very, very important, and you may even do a staged cataract surgery. So this configuration of cataract precipitates are so important to reach the different etiology. For example, sarcoid TB toxo, there will be a large granulomatous, and this gravitational distribution will be there in the herpes simplex zoster, whereas Fuchs will be non-gravitational diffuse stellate. And the most important, the post-nurse Glassman syndrome, there will be medium size or inferior peripheral iodocorneal angles. So the configuration of keratic precipitates are also important. So sometimes keep an eye open, rule out the pseudo-Fuchs, never to miss the sarcoid as well as the syphilis, which are easily the masquerades of Fuchs uveitis. So as you see in this patient, there is diffuse granulomatous stellate keratic precipitates. Even gonioscopy showed this wonderful finding of 10-shaped peripheral anterior synecdoche, which is a diagnostic criteria for ocular sarcoidosis. So why the specific diagnosis we have to break our head? Because the treatment is going to be entirely different. Fuchs uveitis, no topical steroids, no oral steroids. This is the single most take-home message. I keep telling again and again, forgive me. And no cycloplegics pre-operatively in Fuchs uveitis. You all agree there is no synic A and no cycloplegics. As I said, when there is vitritis, don't keep bombarding with steroids. So even general examination is very important. As you can see, when a patient walks in with all the deformities, with fibrinous uveitis, you will suspect HLA-B27. Iris nodules, COPE, you know, it can be in both granulomatous, non-granulomatous. Busaka and angle KPs are very important, looking for TB and sarcoidosis, which is called Berlin sign. And of course, not to miss this neurofibromatosis causing leash nodules. Brushfield flex and Down syndrome, don't keep treating as uveitis. And even this masquerade, there could be a sentinel vessel adjacent to the limbus, and as well as a hyperpigmentation. All these subtle markers are helpful in reaching a specific diagnosis. So what to look for atypicality in hypopyon is, you can see a granularity or even vascularity. The surface is not flat enough. All those should help you to do a specific diagnosis, and that a tap could help us in reaching the retinoblastoma. And the treatment is going to be entirely different in these scenarios. And as you know, biofilms we see post-op, it can be due to Propionobacterium acne, they will have a dendritic capes, and these dendritic capes can happen in other conditions apart from P. acnes like sarcoid, even toxo and fungal as well. Though shifting hypopyon is very, very important sign for Behçet's, we all know that, and not to miss this head tilt test following intravitreal triamcinolone, which could mimic shifting hypopyon as well. This triamcinolone keeps shifting, whereas your hypopyon following fibrinous uveitis may not. And this non-shifting hypopyon could be a marker of infective etiology. So the color of hypopyon is also important. As you can see, the pink colored hypopyon can happen in Serratia, Klebsiella, and Mycobacterium can cause brown colored hypopyon, and there are different colors. You can look for that. So in a nutshell, what are we going to do when the patient walks in? The baseline test, I'll finish in 30 seconds, sir. The baseline test, the complete blood count, Mantoux test for TB, syphilis, chest imaging, and not to miss the TB, Mantoux, quantiferon, gold, and chest imaging. We pre-COVID we were happy with chest X-ray for poor patients. Now for all posterior and pan-uveitis, CT scan is definitely mandatory to rule out the post-COVID manifestations before harping on oral steroids and immunosuppressants. Make sure HRCT is definitely done. Syphilis, we have to do both non-treponemal as well as a treponemal test, and other infectious as and when required. So not to miss the drug induced. I will stop my presentation right now. Thank you for your patient listening.
Thank you, Bala. That was a fantastic talk. Very interesting and very illustrative. Thank you so much.
Thank you, sir.
Yeah.
So now I would like to invite Dr. Jatendra Singh. So he'll be presenting on interpretation of fundus fluorescein angiography and indocyanine green angiography. Over to you, sir.
Thank you, Anand. Thank you so much. We heard two excellent talks, and I'm going to talk on something which is probably a dying art. What Buckle has seen in surgery is probably what FFA is facing in the era of OCTA. This talk is going to be very basic, and I hope the PGs and fellows they learn from something from it. So these are the first thing which I like to stress is fluorescein angiograph or angiogram is not a single image. It's a set of images starting from the early phase, the arterial phase, and going to the recirculation phase. So you have this picture. You are tempted to say that it is probably a normal angiogram. This is a late phase of a patient, of the same patient, where you can see a delayed arterial filling, and this patient clinically you can see that it is a central retinal artery occlusion. So never comment on a single picture. When there is a hazy view due to cataract or vitreous hemorrhage, you probably have to limit the expectations that you can derive. The interpretation of the angiogram has to be limited. So be wise then when there is significant cataract, that is you're not going to get enough information. Probably you can avoid an angiogram and defer the patient after cataract surgery or after the vitreous hemorrhage has been cleared. Sometimes you might be surprised in cases where clinical examination doesn't provide enough information. An angiogram will provide you absolute, clear, pristine view of the posterior segment. So this is the case of asteroid hallosis, where indirect ophthalmoscopy will not able to get clear picture because of the scattering of crystals. But this doesn't hamper the interpretation from an angiogram. Even before you start the dye injection, you can do something called as autofluorescence, put the barrier and exciter filters in, and you can pick up astrocytomas and optic nerve head drusen, which are associated with rod cone dystrophies or certain neurofibromatosis. So this patient presented with disc edema, went to pillar to post, got investigated including CSF tap, and actually it was just a simple investigation which could clinch the diagnosis of optic nerve head drusen. So fluorescence can be either hyper, when there is increased hyperfluorescence from the image, from where you see a normal fluorescence, it can be either more or less. So when it is less, it is either because of blockage, that the fluorescence is there and it is not seen, or it is not there at all. If it is not there, it is a capillary filling defect. If it is blocked, it is because of an overlying lesion. And the size and the shape of the lesion that you see on clinical picture can be correlated with the angiogram, and it can give you a clue that it is a blocked fluorescence. In the first image, you see blocked of retinal and choroidal fluorescence. In the second, you can see some ground glass appearance in the temporal part, but you can see some amount of blocked fluorescence as well. So the color of the hyperfluorescence, how dark it is. If it is absolute jet black, it is probably because of blocked fluorescence. You might see some amount of ground glass haze because of some amount of choroidal fluorescence showing through. The last picture is of a CNVM. You can see the subretinal hemorrhage and the retinal vessels overlying it. So the location, the anterior-posterior location of the lesion can be picked up on an angiogram just by interpreting the hyperfluorescence. So this is a case of ischemic maculopathy. You can see a capillary filling defect involving the macula in a diffuse manner. So hyperfluorescence and hypo are not exclusive of each other. Both can coexist, and very often they do. And this is a case of new vessel with intense leakage and the capillary dropouts. So most likely, most cases, you will see the new vessel formation at the posterior edge of the CNP areas, so capillary dropout areas. So coming to hyperfluorescence basically are of 4 types. We'll go one by one. This is transmitted hyperfluorescence. So you see the window defects and the pattern which is similar to what we call as the crescendo decrescendo. So as the dye increases in intensity, you will see the increase in the fluorescence, and it keeps dropping down and goes to the least in the late phases. These are the leakages. This is a typical smokestack leak seen in case of CSR. Initially, you would see a very small dot, and it would rise from this. And this dye gradually starts pooling in the neurosensory detachment, with the hyperfluorescence most intense at the periphery. This is another patient with a very similar kind of pooling, but in multiple cavities, and the leakage is coming from multiple pinpoint sources. This is the case of leakage. So the point to be stressed here is, if you see multiple pinpoint leakages and single leakages, and single discrete leakages, the diagnosis can be different. This leakage is typically in the cystoid spaces within the macular area, the typical petaloid pattern seen in cases of CME. A classic CNVM would show a lacy network with some amount of block fluorescence if there is hemorrhage around, and this will become intense, and the borders become fuzzy and enlarge. Occult CNVM also, sometimes this might be misdiagnosed as a classic CNVM because it is well defined, but it is not lacy, and the fluorescence that is seen is like remaining the same. The borders are not becoming too blurred because of the surrounding subretinal hemorrhage. So this is a fibrovascular PED, the type 1 type of the occult CNVM. Sometimes you might see intense leakage in the macular area, and on the clinical examination you don't see much, and OCT also doesn't show much of edema. So this is a case of a mactel where there is a abnormality in the capillaries around the foveal area which cause this leakage. The pooling is different. Pooling can happen in all anatomical spaces, most commonly in the neurosensory, under the neurosensory retina or under the RP. So if it is a very discrete, well-defined lesion and remains the same throughout, it is a pooling under the RP, and this hyperfluorescence is generally like completely filling that space. Whereas in neurosensory detachment, it is most intense at the periphery, and there is a gradually declining hyperfluorescence towards the center. So this is not pooling because you can see the size of the lesion and the intensity of the lesion increases towards the later phases. This is a case of angioid streaks to help you differentiate what is leakage and staining. Here you see a lesion which is not the same as the hyperfluorescence that you see here. So this is a advancing edge of a CNVM related to angioid streaks, whereas this lesion in the lower picture shows you a scar and a corresponding hyperfluorescence to that. So the staining of the scar is usually usually well defined, and you can always go back and see clinically and correlate if it is corresponding to the same area. Neovascularization and collaterals can be easily differentiated. You can see the intense leakage that you see from the new vessels, whereas the collaterals will not leak as much. They might leak a little bit, but not as intense as the new vessels do. Abnormal vessels have also been classified under hyperfluorescence. I think it just, if they leak or they are just a structure abnormality, so they do not actually describe a different pattern of hyperfluorescence. So each phase of the angiogram has its own significance. This is a choroidal fluorescence, slightly delayed in the elderly because of the reduced supply. If the choroidal fluorescence or the patchy fluorescence lasts for more than 5 seconds, it is considered as abnormal. Then we have the arterial phase. You pick up arterial AV transit time or the arm retina time in cases of occlusive diseases. The early phase and then the mid phase. Mid phase is the peak phase where we read all the capillary dropout areas. The late AV phases, we read the leakage. In the venous phase, we look for staining and pooling. There are times when we will be posed with this kind of picture, it's all messed up and the angiogram doesn't provide much clue, and ICG comes to the rescue. You can see polyps at the edge of the lesion, and this is the case of a polypoidal choroidal vasculopathy. So switching to ICGA, you can see the multifocal CSR here, but the pattern on the ICG is showing much more wider hyperfluorescent areas. And there are authors who believe that PDT guided, ICG guided PDT treatment has better results as compared to treating just the focal lasers, focal points on fluorescein angiogram. This patient actually presented with a diagnosis of choroidal melanoma with a large elevation in the lower part of the retina with macula involved, and a simple test with ICG picked up a polyp. It was a case of PCV with intense subretinal bleed and hematoma, and we just did the focal laser for this leak and the patient recovered 6/6 vision. So PED can be serous or fibrovascular, and on FFA everything will look white and hyperfluorescent, but on ICG will pick up serous PED as a hypofluorescent area, a hyperfluorescent lesion, and if there is hyperfluorescence within that lesion, it would be the fibrovascular component. So within the serous PED, sometimes you can have patchy hyperfluorescence on ICGA, which describes the or detects the fibrovascular component of the PED. You can also pick up hot spots and plaques. Hot spots typically are lesions which are less than 1 disc diameter in size, and they are supposed to be more active kind of CNVM lesions. The plaques, on the other hand, are wider lesions, more than 1 disc diameter size, and they represent a more quiescent or a quiet kind of a CNVM. The feeder vessels which feed the CNVM area can also be identified in the early phase by doing a video angiography on ICGA, and immediately treat the patient, go back and do repeat angiography and see if the lesion, that feeder vessel has been occluded. If not, it can be the treatment can be repeated again. So this video angiography with ICG gives us almost immediate feedback of our treatment. Coming to some uveitic entities, this is a patient who with mild myopia. You can see some hyperfluorescent lesions on the ICGA. It helps us to differentiate a CNVM lesion which can be associated in myopia, and this is actually a multifocal lesions with hyperfluorescence. Not much of hyperfluorescent areas in the ICGA, and it was a case of a punctate inner choroidopathy. Lesions like azure, you can see the trilaminar flow on the FFA, and it is much better differentiated or seen on the ICGA. The ICGA represents a larger area, and it actually identifies the entire lesion as compared to a fluorescein angiograph, which is affected because of the leakage. This is a patient with myopia. Again, you can see some lesions in the right eye around the disc, some amount of parapapillary atrophy. On the left eye angiogram, you can see fluorescein angiography not providing much information, but the lesion around the disc with some amount of satellite lesions spreading across the posterior pole gives a diagnosis of mutes, multiple evanescent white dot syndrome. So coming to the last image, this is the type 3 CNVM where Uni mentioned that Octa is still not providing enough information. You can see the intense leakage on fluorescein angiography, but on ICG you can see a clear RAP lesion. This is a stage 2 RAP, and it is well picked up on ICG, and direct focal laser or anti-VEGF therapy or combination therapy can be posed to these patients. So I would like to conclude by saying that fluorescein angiography is not a dying art. It should not be, at least I want to believe that, and I would encourage all the postgraduates to learn and understand by seeing more and more images. Thank you so much for your kind listening.
Thank you, Jatendra, for a very insightful talk, and yeah, we'll move on.
So thank you so much, Jatendra sir. So now I would like to invite Dr. Ananda Rajendran sir. He'll be talking on interpretation of OCT, something which is very important irrespective of the specialty you practice.
So OCT is something that has, taken the diagnostic world of retina by storm over the last maybe 1.5, 2 decades, and it's really become quite like what CT and X-rays are for a physician. Okay, so are my slides up? Yeah. Okay. So with time comes, technology leaps, and this is how we used to see telephones in the 90s, and this is how we do now. And this is how we used to see computers in the 90s, and this is how we do now. And similarly, this is how we used to see OCT images around the late, the millennium, turn of the millennium, and this is how we do now. So there have been rapid advances indeed in OCT imaging. So we began with, in the mid-90s, late 90s, with the Stratus OCT, where we had about, a few thousand A scans per second. That's how slow it was. And then you see those gray dots, we moved from time domain OCTs to faster spectral domain OCTs, and most of us are using that still. And to the point that now we have what is known as swept source OCT, which are, as fast as about 100,000 A scans per second. So, this is the this is the original time domain OCT, where reflected light from a sample tissue matched with that of reference mirror, and you see this movement of this reference mirror allows acquisition of depth information. But because there's a moving mirror, moving part inside, it was pretty slow, and we then moved on to spectral domain OCT, which is much faster, simply because there's no moving components, and you get almost all the A scans at one shot. Yeah. And from there, recently, in the last few years, we have moved on to swept source OCT, where basically you have a swept wavelength tunable laser. Instead of only looking at one small slice of the output of a broadband source, naturally limits the signal to noise ratio. All of the light is now collapsed into a single wavelength, and that wavelength is swept across a range of different wavelengths, and this therefore increases the signal to noise ratio and can boost up the speed. So why is SD-OCT or spectral domain OCT helpful? With old time domain OCTs, it measured less than 5% of the mapped area, and errors were propagated across, therefore, a large area. And if those lesions fell between these raster lines, you could miss them. Whereas with spectral domain OCT, as you see on the right side, that whole cube is mapped, and you get 100% of the area, apart from the fact that speed is accelerated 100 times. So this is how we see OCT images now. You see almost all the layers. In fact, they even split up layers out there, and it's virtually optical histology. You see the histological picture virtually simulating what you see on the OCT image. So these are spatial representations. So line scans, the routine ones that we get, are like the two faces of your Rubik's cube, vertical and horizontal. The en face is like the top of the Rubik's cube. That's en face. And put everything together and you get a 3D image of the Rubik's cube as such. So these are representations. This is the surface of the retinal thickness ILM map, and this is how a normal map should look like. Macular edema is where there's a swollen blister in the middle and it's color coded, so you see red and white on top. And epiretinal membrane is like a chewing gum on top in green, and diffuse atrophy is where you get a dimple and this thinning out. So this is the foveal microcosm, as I'd like to call it, and it simulates that central tower of your the foveal zone. So this is your RP Brooks area. Just to let you know, this is your interdigitation zone out there, okay, which is the tip of the photoreceptor. This is the outer segment, okay. And this is that conical area. So this, because all the photoreceptors are bunched in the foveal area, this is thick out here. And beyond this is your ellipsoid zone, okay. And this is at the junction of the outer segment and inner segment. And beyond this, next comes the myoid zone, which is the body of the inner segment. And beyond this is the external limiting membrane. And after that is what you get is the outer nuclear layer and the Henle's fiber layer. So this is, in short, a brief gist of the very central area, which is the most vision defining area, and this is the area that you need to look at to see if patients are losing vision early. So indications can be classified into, the vitreoretinal interface coming from top to bottom, where you can get pathologies like ERMs, vitreomacular attraction, subhyaloid hemorrhage, and we'll see examples of these. Nerve fiber layer, myopic traction, maculopathy, X-linked retinoschisis, plexiform layers, where you'll find pathology of diabetic and cystoid macular edema, photoreceptors, heredomacular degenerations, detachments in all layers, macular holes, and subretinal layers, CNVMs. You can reclassify this anatomy to explain, the same classification to explain the pathoanatomy, for example, macular hole, XLR, CSCR, CNVM, and look at reasons for doing surgery, macular edema, or not doing surgery, macular hole, macular TRD, VMT, similarly indicating futility of surgery in macular edema, HUL also. So coming to AMD, this is an occult CNVM. I think Jatinder and Uni before have described OCTA and FFA features of these. So with the type 1 CNVM, you have the RP elevated. As you can see here, the RP is elevated, there's subretinal fluid here, and there's neovascular material under the RP. And this is an example of a regression. So when anti-VEGF is given, this neovascular tissue just regresses, and you see that bump out there. On the other hand, this is an example of a classic CNVM where you have the neovascular material above the RP, as you can see here. And again, an example of a regression. Once you give anti-VEGF, you see that melts off and regresses there. The subretinal fluid a little bit, and the intraretinal fluid also goes away. An example of a RAP lesion. RAP has different stages. This is an ICG showing the hotspot with the intraretinal neovascularization, and this is seen on the OCT here. These are old images, and this is stage 2, where the ICG shows intensification of this hotspot and serous PD hypofluorescence. On the OCT, you see this bump out there and the intraretinal fluid out here. And third stage is when the RAP lesion dips inside or under the RP. So ICG highlights the retinochoroidal anastomosis with intra and subretinal and choroidal networks here, and you can see this cascading neovascularization with the RC anastomosis. So this is another example of a RAP lesion where you have the disproportionate amount of hemorrhage on the fundus photo, hazily seen on the early and the late phase FFAs. And importantly, you see the RP here and this little clump of neovascularization emanating from the retinal circulation. On the OCTA, you see it better here, and this is the magnified view of the network. Another example where you see the RAP lesion, where right there, the elevated PED, the RAP lesion is diving down under the RP, and you see it on the OCTA here, the network. And post anti-VEGF, you see the intraretinal fluid and the subretinal fluid regressing, as well as the OCTA lesion getting wiped out. This is an example of AMD with a disciform scar. I'd like to direct your attention to what is now being called the outer retinal tubulations. These are giveaway signs of chronicity of lesion. Basically, defunct photoreceptors evaginate amongst themselves and they form pseudocysts. Okay, and you can see these not just in scarred lesions, you can see lesions without scars, which tells you, when you see these, it should tell you that this is a chronic lesion you're dealing with, and it might not benefit from so much from treatment. So these are hard drusen's of dry AMD. I'd like to direct your attention to these, this bumpy sawtooth kind of, appearance. See, the RP is being elevated. Note that the RP is elevated. Why I'm telling you this is because contrast this with the next lesion, what I'm showing you, reticular pseudodrusen's, which is like a rash, like a yellow rash out there, pinpoint lesions, as opposed to the hard drusen's that you see here, which are a little bigger. But what you see here importantly on the OCT is you find lesions, these kind of sawtooth lesions above the RP. So these are actually subretinal drusenoid deposits. So these pseudodrusen's are above the RP. Okay, and now these are soft drusen's. So you see more dome-shaped lesions and little rounded lesions, and you can see that on the fundus photo here as well as the multicolor image there. Geographic atrophy is an advanced form of dry degenerative AMD. This atrophy of the RP and the underlying choriocapillaris, so that because the choriocapillaris layer is no longer there, the larger bore choroidal vessels are seen through. And to be called dry AMD or geographic atrophy, you need to have at least 175 microns or more. So if somebody asks you in the exams, this is the number you have to quote. They're also known as areolar atrophy. This is an example. Again, you can see that clearly, the geographic atrophy on the multicolor image, as well as on the autofluorescence here and on the infrared image here. And you can see exactly this area, the RP is missing, the choriocapillary is also thinned out, and there's a lot of shadowing. Okay. Polypoidal choroidal vasculopathy is another form of macular degeneration that we have come to understood a lot more in the last 1.5 to 2 decades. So you basically, as you can see on the polyps, and has been described again by Jatinder and Uni before, you see these polyps here, and you have this huge massive elevation of the dome-shaped elevation of the PED, and you have this intraretinal fluids, and see post-treatment you can see that settling down very well. So these are different types of PCV, notched PED. So this is a kind of a sign. When you see that, you know that you're most probably dealing with a PCV. This is because there's a polyp under that, probably pulling that PED down and creating a notch there. You have the steep PEDs, you have these hemorrhagic PEDs, the kind that I showed you earlier, serosanguinous, which means just a mix of both blood and serous fluid, and there's the subretinal hyperreflectivity. You can get a cavitation, which is the cross-sectional lumen of a polyp right there. So all these are different OCT features of polypoidal choroidal vasculopathy. Another case where there's again thumb-shaped PD. It looks like a thumb stuck out there, and there's a lot of subretinal fluid, a bit of intraretinal fluid. Again, post-ilia, post-injection, you can see that settling down very well. This is another example of a massive submacular hemorrhage, and you can see again with tissue plasminogen activator and gas, you see that settling down, and then with ranibizumab it settles down further and it regresses completely. So we have seen two forms of macular degeneration, PCV and AMD. In PCV, the choroid is thicker. This is something which is very important, and there's a mode on the spectralis called the enhanced depth imaging, where you can see deeper. So you see this is much thicker than the choroid in AMD, and in fact in AMD it's called age-related choroidal atrophy, because there's choroidal thinning. So even if you have something which looks similar, look deeper, look at the choroid, and you'll find PCV has a thicker choroid more often than not, and AMD thin choroids. Acute CSR is another common disease. The serous elevation, the retina is elevated, and you'll find this fibrin under the RP, under the retina as well as over the RP. And this is the classic ink blot leak. Starts as a dot and then increases. Jatner also spoke about that. Another typical example of acute CSR where there's elevation. Look here at this RP. So this is little hyperreflective here, and there's a large large bore vessel called Pachy vessel out here. And this is the typical classic smokestack appearance that we come to associate with CSR. And this is subretinal fibrin out there. And with just a focal laser, it settles down very well. This is an atypical CSAR with the ink blot leak being distorted. Why is it distorted? The OCT gives you the answer, because there's subretinal fibrin tacking that undersurface of the retina to a leaking PD, and therefore there's distortion. This is a chronic CSR. Just to highlight that this is part of the pachychoroid spectrum, you can see these massive tube-like, choroidal vessels out there. And we just stress this patient that subretinal fluid, which you saw earlier right here, that goes away. So stress relief is is a very important part of conservative management of CSCRs. And you see that little PED out here and these big, massive, cavitary lesions, which are called Pachy vessels, basically thick vessels. Pachy means thick. Another old favorite, this is a CSCR of a multi-pronged rip with the OCT at 3 different levels. Look right here. This corresponds to this one here, where there's a vacuolated subretinal fibrin deposit. So this is a vacuole or a space within, and that shows up here as an area of clearing. On the other hand, when you come lower, there's the area of the rip here. You see there's the discontinuity of the RP. So absence of RP, and therefore this shadowing pass through of the light. And at the fovea here, below here is a little bit of subfoveal detachment, which is why vision is fairly good, 612 for such a massive lesion. And when you did the angiogram, you see this is the leakage, multi-pronged leaks. It's like a white lizard, the tail being on fire, as well as extrafoveal leaks. So this is now moving to diabetic macular edema. You can get some massive edema at times, and this is called skytic edema. You see this entire structure is stretched, and this vertical, it's almost called vertical palisading. Different types are there. This is cystoid edema, which is fairly focal and like a cystoid balloon out there. And this is the same cystoid edema with a bit of subretinal fluid out here. And this is cystoid edema with diffuse subretinal fluid. You can also get a different kind called spongy edema. This is like a cake, like a sponge out there. Okay, it's diffused along the breadth of the thing, and this is spongy edema with subretinal fluid. So these are different morphological types of diabetic macular edema. Branch retinal vein occlusion, macular edema. The clue to diagnose a BRVO is one side will be thickened, the other side will be fairly flat. So you see the scan passing through this area. So this side is normal, and this is the macular BRVO right here, and this side is thickened. So when you see this, you should be able to say that this is a BRVO. Similarly, it regresses very well with anti-VEGF, and you see the regression. Similarly, CRVO, you have a mountainous edema. So it will be on both sides, and you can see that tomato ketchup kind of thing on the appearance on the infrared, and again regresses well with anti-VEGF. Another example of the same. Macular holes, we need to, OCT tells us a lot about pathogenesis, when to operate, when not to operate, how fast a hole could close, when ILM peeling is not critical, why vision did not improve. So this is the classification which has been put out first by Gass and Godric, gave us an OCT correlate, so you can read about it. So these are the different stages. So this is stage 2, where this is just lifted up, the flap is lifted up. This is the stage 3. I'll just finish in a couple of minutes with the operculum here, and this is a full thickness macular hole. So this is a stage 2 macular hole. You can see the pre-op 624, and then post-op improves. And this is stage 3, and post vitrectomy and ILM peeling. This is a macular hole with rhegmatogenesis detachment and settled after vitrectomy and putting in oil. And this is a diabetic macular detachment. You can see the traction there and a stretch hole out there. And after vitrectomy and settling, removing the traction and putting in oil, you can see it settling there. This is trauma. So this is trauma. Here you can see that settled commotio retinae. You can see this scan taken here. You can see one part of it is atrophic. So this vision patient will definitely have poor vision. And this is vitreomacular traction, so which is pulling on the macula, and you can see different varieties with the outer lamellar hole out here, and with full thickness macular hole with epiretinal membranes, with tractional macular edema. And these are cases where you can operate and you should operate, and you'll have good outcomes. Whereas other where you have degeneration or scarring out there, these are cases where probably you won't have great results. Probably should not sing. I'll skip this kind of case. Am I out of time? Almost out of time. Okay, so this is a very interesting case which I quickly want to show you. In the left eye, the patient had a macular hole, went in for surgery. In the right eye, look what's happening. A traction is developing on in the fellow eye at the same time that the left eye is getting repaired after the ILM peeling vitrectomy, and you see that traction develops and that breaks off spontaneously. And a few months later, even though patient was advised surgery in December 2019, patient didn't want to take the other eye surgery so soon, and you see the spontaneous improvement. So just to show you an interesting case, an epiretinal membrane you can see right sitting on top like a cap out here, and resolution post-surgery. Inflammation, Koyanagi Harada, which Bala talked about. You can see the corrugated choroid. So this is important. When you see a corrugated choroid, you know there's something happening from the choroid, and that on the other eye you can see subretinal fluid also. And with just steroids, you can see the improvement, the anatomical restoration. a case of posterior scleritis with multifocal serous detachment, as you can see here. And this is interesting because you can see that the inflammation, the turbid subretinal fluid, and this little tack pulling up the PED. So when you see a conical PED like this, know that this is not CSCR. This is inflammation. Conical PEDs can happen largely only in inflammation, and it just melts off with steroids. Another example of an APMPE, and you can see here, this is an interesting finding where you find just the outer retina being split and the edema right there, intraretinal edema, and this is called a bacillary layer detachment sign. A dome-shaped maculopathy is something you get in myopes, and especially if you have the scans running in the vertical side. A myopic CNVM, I'll run past this. Same thing, you can see a very thin choroid. I like to direct attention to this very thin choroid here in the myopes, and the CNVM melts off with anti-VEGF injection. Some examples of macular schisis, X-linked retinal schisis. I mean, this is myopic tractional maculopathy. You see the dome. When you see on the OCT a dome like this, you know you're dealing with a myopic case because of anteroposterior traction. The macula is split, the retina is pulled up, and you see this kind of example. This is an example at the fovea. You can see there's a CNVM and a different.
Anand,
you can see
running out of time. They've stopped the timer. Some problem.
Okay.
Can we just conclude?
So I'll just quickly just conclude with telling you that OCT is a great non-invasive diagnostic tool, elucidates pathogenesis, points out surgical indications, prognosis, helps follow for treatment cases, and shows up poor cases of recovery, and explains unusual disease presentations. Thank you.
Excellent talk, Anand. Thank you so much.
Thank you.
With that, I would like to invite Dr. Giridhar. He's the director of Giridhar Eye Institute at Kochi. Please take note. Oh, they stopped it. Went beyond. Okay, but on that screen they used to have a timer, no? वो बंद हो गया.
ये एक इसमें टाइमर
नहीं, उसमें वहाँ पे बंद हो गया टाइमर.
कहाँ?
ऊपर वो आ रहा था ना इंसेट में.
गिरिधर.
इंसेट.
Yeah, that's right.
They stopped it. यहाँ पर वहाँ पे आना बंद हो गया. ब्लू में आ रहा है ना. That was not showing.
Okay. So, good morning, and nice to see the hall slowly filling up. And after all those wonderful talks on various diagnostic modalities, I'll be talking on multimodal imaging. I don't know how I ended up in this session, but probably because we wrote recently a chapter in the NEMA's book on multimodal imaging, which has had a very good feedback. A lot of people have sent emails saying that is quite interesting. Anyway, what I'm going to do in the next 10 to 15 minutes, you can stop me if I'm crossing the time, is basically to make you all understand how we can apply multimodal imaging in retina practice. It has become multimodal imaging, I think today has become an essential tool in the diagnosis, prognostication, and management of many macular diseases. And basically, what is multimodal imaging? Can anyone tell me what is how do you define multimodal imaging? Can you tell me how do you define multimodal imaging? Multimodal imaging is presently defined as using more than one imaging modality for the diagnosis or prognostication of a particular disease. So that is actually the definition that has been given. More than one imaging modality. So you may use 2, 3, 4. So if you use OCT and autofluorescence, it becomes multimodal imaging. You understand? So with this, you got a whole array of diagnostic. You can see here OCT, which Dr. Rajendran spoke about, autofluorescence, Octa, which Dr. Unni Nair spoke about, and we are going to have some more talks on, we already had talks on angiographies, both ICG and FFA, which Jatinder spoke about. So basically it involves multiple imaging modalities, and you may not use everything in every patient, so you use what is relevant in a particular case. So with this introduction, I will just show you a few cases. Actually, I made this talk very recently in another meeting, and I'm just, changing the way I present this for for this particular session. Now, this is an elderly patient with a long history of wet age-related macular degeneration. The left eye is being treated. Now, can you tell me what do you see in the OCT scan on the left side there? What do you see in the scan there? Quickly, what do you see? Okay, it's not CSR. Now, that is basically a case of wet age-related macular degeneration. And why it is wet? It's good. I mean, it's either a CSR or a type 1 neovascular membrane. What you see is serous macular detachment, isn't it? But along with the serous macular detachment, you also see an irregularity of the retinal pigment epithelium. And in any elderly patient, 80, 82 years old, this is most probably a diagnosis of wet age-related macular degeneration. Now, what do you see in this particular photograph here? Quickly, because Rajendran will ask me to stop. Hypoautofluorescence. Now, what do you see in this particular photograph from top to bottom? What do you see? You see the area of hypoautofluorescence is slowly increasing. So, over a period of 10 years, the area of atrophy is slowly increasing, although the vision is more or less the same. So, this is how we use multimodal imaging. So, although the patient is doing well, we know that atrophy is slowly increasing, and that atrophy is slowly reaching the center of the macula. So, autofluorescence is a very useful imaging modality to understand the functional status of the outer retina. Okay. So, this is another patient. Now, this is a case I've already written the diagnosis. So, good vision, elderly man. Now, what do you see in this OCT here? You see those small, now only just now Dr. Anand Rajendran explained to you a lot of things. Now based on that, what do you see in this particular OCT? Drusen. So focal elevations, you must say, see, OCT is interpreted based on OCT language. From OCT, you say focal elevations of the retinal pigment. So you see drusenoid changes. Now when you see this autofluorescence, now this is an autofluorescence picture. You agree with me? Now from the top one and the bottom one, what is the difference you see? Top one, bottom one. What do you see? Difference? Hypoautofluorescence. So areas which were hyper earlier have become hypo. So again showing you that this patient also slow progressive decrease in vision he complains, but no cataract, but basically atrophy is increasing. So again, so autofluorescence is a very useful tool along with OCT to understand the functional status of the outer retina. Now this is the case number 3. Now what do you see in this picture? What do you see quickly? RP. So what is your diagnosis? So it looks like a case of a central serous chorioretinopathy. That's what I also thought. This patient requires central serous chorioretinopathy. Now I'm doing OCT. So first photograph CSR. Now OCT. Now in OCT, what is your diagnosis? You can see here OCT passing through that serous macular detachment. What is your diagnosis? So in the OCT also CSR. Looks like CSR or something else. So pachychoroid, yeah, he's got a little pachychoroid, and you see a little bit of an elevation of the retinal pigment epithelium, what we call as a FIPED or whatever double layered sign, whatever you want to see, and that area is little hypertrophic. Now I'm taking multiple sections. So whenever you are having a machine and whenever you have a disease, you must analyze the OCT not with one picture, one scan, but all the scans together. Then otherwise you will miss something. Now what do you see here? In the top one, what do you see? You see a PED. What type of PED can you tell? Peak PED, not bad. So you got a peak PED with a serous macular detachment. And when therefore what I did, we did an ICG. So you titrate your multimodal imaging, color photo, OCT. Then you decide what to do, ICG. Okay? So now you do an ICG. This is a case of a polypoidal choroidal vasculopathy. Therefore, using multimodal imaging in this particular patient, we diagnose, you can see beautifully now, this is a classic picture, which beautiful pictures already Dr. Anand Rajendran has shown based on our work that we did many years together. So you can see that tall peak PED there. Now this is another patient. Now this patient actually, you can see here, he has had CSCR 30 years ago, very good vision in one eye, other eye, little bit of a visual problem. Now if you see the color photo, do you see anything here? Very difficult to say anything, right? You can't say anything much, but in my photo here, I see patches of suspicious serous macular detachment and as patches of RP atrophy. So this is a case of CSR, right? This looks like CSR, nice serous macular detachment and CSR. But unfortunately, again, you see multiple sections. So CSCR can mimic many conditions, especially in elderly people. And that is one of the important indications for doing the multimodal imaging. So just earlier, we used to do only OCT. But now when we do all this multimodal, many cases of CSR are diagnosed as some other condition. Now this is another very interesting case seen by one of my colleagues. Now you see this one, again you see just patches of RP atrophy, everything marked beautifully in the chart. Patient is complaining of defective vision in the left eye. And then again, what do you see in this color photo? Quickly, what do you see in this color photo? RP atrophy, the patches of RP atrophy are seen in both the eyes, isn't it? Paramacular area, close to the fovea, there are patches of RP atrophy. Now you see the OCT. OCT shows, what does it show? Apart from the serous macular detachment, what does it show? Two things it is showing. It is showing a very thick choroid. You see the choroid? Very thick. The choroid, and the outer choroid is dilated, what they call as Pachy vessel or Haller's layer dilatation, etc. Okay, so serous macular detachment. So this looks like a central serous choroid at all sections. You see there is not much abnormality in the retinal pigment epithelium, no irregularity, much, very little. Serous macular looks like a chronic case. Why it is chronic? Why it is chronic? You see the roof of the serous macular detachment, it is hyper-reflective. The roof of the serous macular detachment will be hyper-reflective, and you will have multiple dots within the serous macular detachment, hyper-reflective. Therefore, that means the fluid has been there for quite some time. Okay. Now you do the ICG and the FFA. Okay, because why? You want to reach a diagnosis, whether it is CSR. What does the FFA show? Nothing much. It just shows some staining, right? You see in the paramacular area, there is little bit of staining, but nothing much. ICG, little dilated vessels. That is all. So, based on OCT and ICG also, it is a case of, looks like CSR. But since the patient is little old, we are not very sure. We are still worried. The other eye also showing a similar picture. You understand? Just some staining, no focal leak, which you see in CSCR, no smokestack leak, no multifocal leak, like what you see in CSCR. So eye diagnosis could be a resolving chronic central serous chorioretinopathy. But considering the age of the patient, you see the autofluorescence also, increased autofluorescence can be due to fibrin also. You understand? It need, or due to RP dysfunction. So, but then finally we did an OCTA because we thought that it could be a CNVM because of the old. So OCTA shows neovascular network. So in elderly patients, we use multimodal imaging like this. So although the other tests were not conclusive, we do the OCTA. Nowadays we do it early. But what I mean to say is that the stepwise use of multimodal imaging in this thing. Okay, macular telangiectasia. Now this is the last thing. Okay, now you see, now what do you see here in this picture? What do you see in this picture? Pigmentation in the red. So parafoveal pigmentation, very diagnostic of mactal. And then what do you see in the left picture? You see one dilated vessel. You see the right angle vessel there? That side, I remember not probably in the photograph. So this patient during follow-up, what happens? The pigmentation increasing, but other eye, little bit of fluid-like thing. You understand? So now the right eye, classic macular telangiectasia, but left eye has got serous macular detachment. You can see there, but there is an elevation of the pigment epithelium also, and he has got a neovascular network. You understand? So therefore, OCT is very useful. When you see the serous macular detachment, you are doing the other imaging technology, modalities, and actually this is a patient who is having underlying basically a neovascular network in a case of macular telangiectasia. Now this is my last case. Now the left eye. The left eye looks very normal. Right eye classic mactal. Left eye looks very normal on the photograph. But if you do the OCT, you can see one small area of ellipsoid loss. There are many causes of focal ellipsoid loss in the fovea apart from macular telangiectasia. You understand? Ocular maculopathy, so many conditions are there. Solar retinopathy. But using multimodal imaging, you can diagnose mactal in the other eye, focal ellipsoid loss, increased autofluorescence, parafoveal, very important to diagnose early mactal. You understand? Early mactal. Therefore, although photograph looking normal, careful OCT small defect, and in autofluorescence you can see this increased autofluorescence. Therefore, using multimodal imaging, early cases of mactal you will not miss. You understand? So, this is my last case. It is very useful in inflammatory macular diseases. Now, if you see this patient, you can see one small multiple yellowish lesions, isn't it? And if you see very carefully, you can also see some little bit fluid and also something red in color. Now, if you do the OCT, therefore you see, I mean, nowadays how diagnosis improves. So, you see the OCT. What are you seeing in the OCT? In the OCT, what are you seeing? Multiple hyperreflective material. Multiple hyperreflective material which is collected above the retinal pigment epithelium, and there is some degree of retinal, therefore this we call it subretinal hyperreflective material. It is seen in many conditions, but in this condition it's a sign of possibly neovascularization. So in an inflammatory macular disease, coexistent neovascularization can come, and that can be diagnosed with multimodal imaging. Okay, so we do the fluorescein angiography. You can see that area where there was little bit of hyperreflectivity, there is minimal leakage. You can see the leakage, and therefore this patient was treated with anti-VEGF injections. In follow-up also, it is very useful to see for recurrence. Now, if you see the left side lower autofluorescence, you see patches of decreased autofluorescence and surrounded by hyperauto. So, the presence of hyperautofluorescence, especially in cases like serpiginous choroiditis and all, the PGI group has beautifully demonstrated how increased autofluorescence is a sign of activity. So, in inflammatory disease also, it is a very useful method of application. So, in conclusion, multimodal imaging has got a very, very important role to play in the diagnosis, prognostication, and follow-up of many diseases in the macula, and we should use it, titrate it according to each case. Thank you.
Thank you, sir, for bringing everything together. Sir, very beautifully demonstrated through multiple examples the value of multimodal imaging. So, yeah, please. Thank you, sir. Thank you so much. So, yeah, we'll move on. Okay. So it's my pleasure to invite a very dynamic and talented speaker, Dr. Mohit Dogra, who's going to be talking to us on ultrasonography interactive. Dr. Mohit is a consultant at the PGI Chandigarh Advanced Center for Eye Diseases. Welcome, Mohit.
Apologies, sir. I had a couple of prior engagements in the other session, so I apologize for coming late.
Only you, Then she's here. Sure. Thank you.
Apologies for coming late. This should have ideally happened before. The ultrasound is supposed to precede angiograms and OCTs and multimodal imaging, but let's see whether black and white photos can still capture your imagination. So I'll try and make it a little bit interactive, right? Because that's the brief that was given to me. So what are the indications of ocular ultrasound? And I'm going to be purely talking about the posterior segment posterior segment uses of the same. We're not going to talk about ultrasound biomicroscopy or doing just biometries or whatever, right? So if the media is opaque, you obviously want to know the status of what is behind that opacity and you want to do ultrasound. You might want to do it in a clear media as well. That's typically in cases of choroidal detachment, if you want to know what kind it is, whether it's resolving or not. Maybe we'll see that down the line. You want to definitely do it in ocular tumors. It's both diagnostic and also prognostic for follow-up. In cases of ocular trauma, I think it's a must. Intraocular foreign bodies, detection and localization. So, we were taught ultrasound by, my mentor, Professor Ramandeep, and he's very passionate about ultrasounds. We do a lot of ultrasounds, and I would try to simplify this. Hopefully, and we've actually written a couple of chapters together, sir and I. And I'll try and spell it out in as many words. I'm not going to get into an axial scan is this, a transverse scan is this. All of that is there in text, in literature. Let's just look at some of the practical aspects. How do you try and interpret an ultrasound scan from the broad general perspective without getting into minute nitty-gritties, right? So typically, the beauty and the issue with the ultrasound is that it's operator dependent. It's not like an X-ray or a CT scan film that you get and everybody gets to see the same image. If I do an ultrasound, it might be exquisitely poor. Whereas if someone on the panel does it, I'm pretty sure they'll be able to pick up a lot more because they're more experienced, they're better. So it's operator dependent, it's skill dependent. It'll show you what your mind wants to try and see. It's not like an X-ray where there is a consolidation in the chest. I can see it, you can see it, everyone can see it. So skill is important. Hence, I'm going to try and break this down. And just going to quickly start with the example. Both of these look similar. I mean, there's some point and some dot-like echos, typical ultrasound. What do you think this is? Well, the first one is vitreous hemorrhage. The second one is early post-op endophthalmitis. And herein lies all of the difference. And maybe by the end of this, we're able to come to why confidently, or at least semi-confidently, you can say that. So whenever you're looking at ultrasound for the posterior segment, the things that you want to look at is, anytime, just look at whatever that black... I'm sorry, this is a bit of an interruption. So whether there are multiple white dots, so predominantly, is it a dot-like appearance? Whether there's a membrane, the membrane can be close to the retina, in the mid-vitreous, there can be multiple membranes. So either dot-like echos, membrane-like echos, or mass-like echos. Or mass-like, not echos, but mass-like structures. Sorry. And the mass-like structures can again be either solid or they can be cystic appearing. This is the first thing. And this is very, very easy to do in the first couple of seconds of the ultrasound that you see. Multiple dots, multiple membranes, single membrane, dots with membranes, or predominantly a mass, right? अब चलने दो कोई बात नहीं अगर हो भी रहा है तो thank you. So when you talk about dot-like structures or dot-like appearance, so it's either due to vitreous hemorrhage or there are exudates because due to endophthalmitis, and it's that is the age-long debate how you try and differentiate them. It could just be vitritis, which could be secondary to non-infectious or infectious uveitis. It could be senile degeneration of the vitreous. Everybody gets it. Even that'll, if you can see it clinically, the ultrasound can definitely see it ultrasonographically. And it could be asteroid hyalosis, or it could be retained silicon oil droplets. We'll soon try and see what these different examples are and focus on multiple dot-like echos, vitreous hemorrhage versus endophthalmitis. Right? You have this. So multiple point-like echos. It's the internal echo intensity is low. Small dot, few lines, but they are majorly dots, right? So let's just mentally put it into the bracket of dot-like echos. Homogeneous all over. Reflectivity is low. None of these videos are running, unfortunately. I actually transferred this from another one, so I'll not be able to show you any dynamic scan, sorry. But you'll have to trust me on this that. So a dynamic scan is you give verbal cues to the patient and you ask them with the eyes closed to move their eyes up and down and right left, and your ultrasound probe stays where it is. And after the patient stops moving in a particular direction, the globe stops moving, you try and look at what the dots or the membranes are doing. If they stop soon after, then that means there is no after movement. The globe stops, the structures inside stop. However, if the globe movement has stopped, but the structures are still moving, then that means there is an after movement. So this is a kinetic ultrasound in which you give verbal cues to the patient to try and move the eye. So on that, if there are after movement seen, then it's a fresh vitreous hemorrhage. There will be differentiation between fresh and old. Now, if you want to look at, now this is old. Now, once like with anywhere else in the body, once there's blood present anywhere long enough, it'll dehemoglobinize. It'll also start to maybe try and get thicker. It might get fibrosed. It might get, basically the body will try and clear it. And the steps till clearing are all of those. And ultrasonographically, they'll be picked up that the low echo intensity, again, I'm sorry, it's just going again and again, that the uniformly low echo intensity on A scan will now no longer be as uniform, because there will be some part of the blood which is dehemoglobinized, some which is not. So depending on where you pass the scan from, it will be high or low. Secondary, because it's gravity dependent, most of the blood is going to be in the inferior part for the most of the time, except when the patient is lying down. It's going to be there's going to be more blood inferiorly, and inferiorly it's going to get more dehemoglobinized, and there'll be a higher echo intensity, more distortion, more dots, more lines. And I'm going to just talk about dots and lines inferiorly, which pretty much tells you it's been there for some time, and it started to form what is on ultrasound called a pseudomembrane, because there is no membrane. It's just appearing like a membrane because that's how the blood started to dehemoglobinize and the body is trying to get it out, as you can see here. Now, as I said, once blood is there in the vitreous cavity long enough, it'll start to dehemoglobinize, go away, or the body will start to try and get it out. They will be layering, they will be inferiorly, it will be thicker, there will be pseudomembranes. However, there are two exceptions to this. If there is a vitrectomized eye, let's say you've done a diabetic vitrectomy, the patient had a rebleed. Now there is no vitreous gel to kind of hold all of these things together. So it'll be homogeneous, as you can see in the top left scan, multiple dot-like echos, and they will remain like that until they either clear by themselves or by something that you do. They will not cluster down inferiorly because there is no gel anymore. It's all aqueous. So there'll be no pseudomembrane formation. It'll not get into chronicity. It'll change color clinically, but there'll be no ultrasonographic difference. And if you get a fresh hemorrhage in a syneretic vitreous, you will still have the same. You will not have changes like we just talked about in the previous slide about chronic old blood in the vitreous cavity. So two exceptions. Now, if you have heterogeneous, similar-looking multiple point-like echos, heterogeneous echo texture, and it's low reflectivity, but it's not uniform, right? Some are low, some are not so low. So they are low, but they're not uniform. And you can see that there's a differential kind of. It's not spread all over. It's not equal all over. It's either more posteriorly towards the retina or more anteriorly towards that. It could be, could be wherever. These are soft clues that can tell you that this might not be hemorrhage. This might be something else. And of course, the clinical presentation, the clinical picture, all of us know that is very important. If a patient comes after cataract surgery with the hypopion, and you look at this and you say, ye to vitreous hemorrhage hai, well then good luck to you, right? Because for that patient, the diagnosis is writ large, there is endophthalmitis, right? So the clinical picture has to go hand in hand, but despite the clinical picture, I'm talking about borderline cases. So if you have non-uniform, low to moderate internal echo intensity of multiple dot-like echos, and you have differential placement of those echos, maybe more posteriorly, lesser anteriorly, or the other way around, depending on what the source of the infection is. If it's a post-cataract surgery infection, let's say, which is the commonest, it will be more anteriorly because that is where the source of the infection is. If it's a metastatic or endogenous end-off, you'd expect more of those echos to be posteriorly. But depending on what the source is, all of these are soft ultrasonographic pointers that you're probably not dealing with blood, you're dealing with exudates in the vitreous cavity, right? Again, I can't show you that on the And again, this is, the clinical picture is important. You see a clinical picture like that, it's a no-brainer. Surgery, red, congested eye, pain, poor post-op with visual gain, fibrin, there's a hypopyon as well, clinical signs are there, and typically, there's retinochoroidal thickening. This is endophthalmitis. So clinical picture in this case, fair enough, but a lot of times it will be subtle, or the media will be opaque, and you'll need to make a differentiation, especially when it's this versus old blood, when the blood is also yellow looking. So those are some of the pointers that might help you. Now, I'm going to skip that. That's not. Yeah. So the important differentiating features between this is that PVD is more extensive when there's a vitreous hemorrhage. Generally, it'll tend to, because by the time you see an endophthalmitis, it'll not give you a very long time to for the eye. So either it'll get better or it'll take the eye with it. Vitreous hemorrhage will stay in the eye longer. And generally, it's the body will have a time to actually develop a PVD. So PVD you'll see more often in cases of vitreous hemorrhage, only because this is non-inflammatory, only because the eye will be able to sustain it for a longer period of time. Pseudomembrane formation, very important. Older hemorrhages, inferiorly, we talked about this, clumping, gravity dependent, it's going to form pseudomembranes, very, very suggestive of vitreous hemorrhage, old. And of course, in endophthalmitis, clinical signs are important. If it's a pain, red eye, then let's not be talking about vitreous hemorrhage, no matter what the ultrasound is saying, right? Now, same features as in endophthalmitis, low to moderate internal echogenicity, except that, the dot-like echoes are a lot lesser. Again, the dynamic ultrasound, this is not going to play, so I'm not going to look at that. This is vitritis, because it's essentially the same thing. It's marching out of lymphocytes into the vitreous cavity. It's just happened to a lot lesser degree as compared to what it would do in a fulminant, full-blown endophthalmitis. So features similar to endophthalmitis. So you typically see this in let's say, intermediate uveitis, again, or a hypopyon uveitis or whatever. This might look like an endophthalmitis, but there are chances, but you have to differentiate, again, clinical history, past history, fellow eye, frequent attacks, other things, patient's already a known case, and all of those things. So that will help you differentiate and categorize the patient correctly as just as anterior uveitis or pan uveitis, and your workup and your treatment and your management will actually be based on that. That is asteroid hyalosis. I'm quickly going to go over that. I think spending time because I want to definitely discuss the membrane-like structures and then ask four questions of you, and then that will be that. So just wanted to ask, what does that ultrasound show? That's all the information I've given you. The history of trauma 3 days back. The axial length is 12.7 something, and the patient says prior to trauma, मेरे को सब बढ़िया दिखता था, sir. So what's going on? Sorry, this keeps happening. The eye is small, right? So did the patient suddenly develop microophthalmia because of trauma? So this patient, history of trauma, occult scleral rupture somewhere, ultrasound done, CDLs most likely would have been positive. This is hypotony. Pressure is low. So you're artificially inducing microophthalmia, that in the patient. And you can see the retinochoroid is thickened. And sorry for this happening again and again. But, that's because of the pressure that's being applied on top of the lid for the eye. So what I'm trying to say is the clinical scenario is very, very important. Had I just shown you that, you should have asked me, some other questions. Ki kya hua hai, sir, aur kya hona hai? So tough one to begin with. I'm just going to ask you, this is not a put together 2 or 3 images, and this is the regular ultrasound that you do. So you can see the whole globular crystalline lens, you can see whole of the vitreous, and you can see a lot of the anterior segment also. So is this some special kind of ultrasound? I'm going to quickly finish. So again, the ultrasound, you place the ultrasound there, it's going to, based on the wavelength, it's going to try and image a part of the eye. If the eye is outside, so this patient had an anterior staphyloma, the eye was there. The eye was there. So you image the eye, the ultrasound depth penetration is going to be the same. So you'll be able to see a lot of the AC, all of the lens, and all of the vitreous, right? Tough ones, just trying to maybe open your mind a bit. I'm going to just show 2 more cases, sir. I know the time's up, and then I'm going to quickly yeah. So we talked about membranes. I think it'll be difficult counting how many membranes are there. So you only have 2 things that you can get. You can either have a posterior vitreous detachment or you can have a retinal detachment. So let's say this is posterior vitreous detachment. That is retinal detachment. Or whatever. What are the other ones? Multiple retinas. Anybody. Lots of membranes, right? This is not a figment of my imagination. So one is retina. What are the rest? Having multiple sheets, the antiretinal tears find the retina is off. Again, why multiple sheets? Vitreocysis. Now this can't, I mean, you can't get a better image showing multi-layered vitreocysis. So you have 1, you have 2, you have 3, you can have many more. And mind you, the retina in this is attached. So all of these are vitreous, right? And just going to show one kinetic ultrasound. Once I realized my videos aren't working, I introduced one more. So this is a 30-second video, and I'm going to stop after this. I'm asking the patient to look up and down, and you'll see that the globe is moving. So what do you think it is? I think you were able to see most of it, right? The patient was moving. There was a triangular structure attached to the disc, and there was an echo-free zone after that, and there was some membrane-like structures 360 degree in the periphery. Any idea what it can be? I'll give you some history. He had trauma a month back. Had PL vision. No, it was a closed globe trauma, very severe. Had hyphema, and I've been following him up on this ultrasound since then, and he's getting better. So he had kissing choroidals to begin with. They were hemorrhagic. They're now getting better. So now he has just a tiny sliver of them at the end. However, because this is a non-vitrectomized eye, because they are kissing choroidals, right? All of the vitreous and everything has been bunched together like that. So that stalk that you see after the choroidals have gone back, all of the muck, the vitreous, the debris, and all of that is kind of appearing like that. So when you examine this patient clinically, if you take a look at him with the IO, the media looks very poor. If you look at the side, it looks very nice, because then you're able to see past that central collected debris and through that echo clear zone. So that was the idea, to show the kinetic ultrasound, what you can look at, not look at, and hopefully see. And thank you.
Mohit, very interactive, very interesting and insightful discussions on ultrasound. So it's my pleasure now to invite Dr. Purna Chandra from Narayan Netralaya, who's going to talk to us on clinical interpretation of electrophysiology.
So, good morning, everyone. I would like to thank Rajendran sir and AIOC for giving me this opportunity. So, before he connects, how many of you made an attempt to read about ERG? Honest? No. Fine. Huh? Fine. I know, like, even as a postgraduate, even I did the same. So this is something which used to run away, because somehow we are not comfortable looking at the waveforms. So we feel confused, and we always assume that this is something recent advance. I will read late during the exam and all. But this is not something which comes under recent advances. This technology is there since very long time. And irrespective of the, like some of you are going to become specialist in various things, cornea, glaucoma, retina and all. So irrespective of the specialty you practice, ERG is something which everyone should know. So from exam point of view, just concentrate for next 15 minutes. You'll be able to write in theory and you'll be able to answer whatever that's been asked in the Viva, the spotters, and some of you might attend interview for retina fellowship. There also they might, if you answer well about other things for extra marks, they may ask you about electrophysiology also. Fine. So what is ERG? It's the mass response of the retina to a luminance stimulus. Simple. Just stimulate the retina with light. What happens? There will be biochemical and ionic changes in photoreceptors and RPE, which generates electric potential, which is recorded as electroretinogram. As simple as that. Stimulate the retina, action potential gets generated. That's what you're recording it as, electroretinogram. You know, just like in ECG we have PQRS, here also we have A wave, B wave, and oscillatory potential, and sometimes C wave. A wave is from the outer retina, that is from the photoreceptors. B wave is predominantly from the bipolar cells with some contribution from Muller cells. And along the ascending limb of B wave, you can see some small deflections over there. That's what we call it as oscillatory potential. And these are from amacrine cells. So your Viva ends here. Most of the time, most of the examiners, they won't go beyond this. If you answer this much, it's okay. But if you get a theory exam and all, if you have to write some FRCS exams where there will be MCQs, where they give spotter, they expect you to answer little more. Fine. So there are different types of ERG. One is full-field ERG, which is the response of the entire retina. So the pattern ERG, which is predominantly from the posterior pole, and multifocal ERG, where we check each and every point on the posterior pole. So don't get confused. There are different types of ERGs. So this is how a full-field ERG printout looks like. So the whatever that is in the blue is normative data of that machine, and the black waves belongs to the patient. Fine. So let's understand each and every waveforms. So before we do a full-field ERG, we need to what we should do. We should dark adapt the patient for minimum of 20 minutes. He has to sit in pitch dark room with eyes padded. During these 20 minutes, if there is exposure to sunlight, you need to repeat all that again. So basically, what are you doing here? By doing this, you are silencing the cones. So only the rods are active. In that dark adapted state, if you stimulate the retina with a very small intensity of 0.01 candela per centimeter square, what you get is a predominantly a rod driven response. Clear? There is no contribution from cone here. And once you increase the intensity of stimulus, the A wave also starts appearing. So the cones will also start contributing. This is what we call it as combined response. Okay. So after that, we light up the patient for minimum of 10 minutes. We'll ask him to sit in an ambient light. In that state, if you stimulate the retina, what you get is predominantly cone driven. I'm using the word predominantly. I'm not using the word only. Predominantly cone driven response. In the same light adapted state, if you stimulate the retina with 30 Hz flickering light, it is only cone response, because for such an high frequency, rods can't respond at all. So understood? We started with an isolated rod driven responses and ended with isolated cone driven response with a spectrum in between. So whenever you look into the ERG, that's all you need to look. Whether the rod component is affected, whether cone component is affected, whether both are affected, are there any negative waveforms? That I'll come to it later. So clear? Any doubts so far? Nothing. So that's what I was telling. Just look whether rods are more affected, cones are affected, both are affected, or any negative waveforms. So now that is about the full-field ERG, which is the response from the entire retina. Now coming to the pattern ERG. So this is the response to a contrast, that is checkerboard. So what did we use in full-field ERG? We used a luminance stimulus, that Gans fold. Here we are using a checkerboard. Okay, so don't get confused with the pattern VP, that is different. Okay, so this is pattern ERG. And there is no contribution from the peripheral retina. I told you, right? This is predominantly from the posterior pole and the macula. So here also we have some waveforms. The first positive deflection, the prominent one is the P50, which assesses macular function. And there is a followed by a negative deflection, which is N95, which is for the assessment of ganglion cell function. Basically, it complements the VEP to distinguish between a optic neuropathy and a maculopathy. If you have a patient where some macula is affected, the P50 will be low. The N95 could be normal. Similar way, it complements the full-field ERG, whether the disease is localized to the macula or it is a generalized thing. For example, if you have a lesion at the macula and you do a full-field ERG, if it is normal, and pattern EEG is abnormal, that means it's indicating it's a localized disease. Okay, so I'll give you an example. If you have a patient of advanced glaucomatous optic atrophy and you do pattern ERG, what will be the findings? What will happen to P50? It will be normal because macula is normal, provided it does not have any other macular pathology. What will happen to N95? Reduced. Okay, let's take an example, advanced age-related macular degeneration with geographic atrophy. P50 will be low. N95 normal will also be low because macula has to get stimulated for the ganglion cells to fire. So that's how we interpret. So then comes multifocal ERG. As I told, to detect even small foci of retinal dysfunction, we stimulate multiple points on the macula. Okay, so we use either 61 or 103 hexagonal elements depending on the area and the finer with what we stimulate the retina. Each and every light point will go and stimulate the retina, and we'll get a waveform corresponding to each and every point which gets stimulated in the macula. Okay, so that's how we detect even a small foci of retinal dysfunction. Where do you use this commonly? You must be getting a lot of reference from your rheumatology department, right? In HCQ toxicity, mainly in drug toxicity, or any case where everything is normal but the patient is complaining, the only thing which can tell us the answer is multifocal ERG. So that's about the ERG. Before going to the case example, just a couple of slides on electrooculogram. Sometimes it may come as short note or a long note. So I don't know, the pattern has changed now. The question, I don't know how it is. Still that short note and long note still exist? Just 10 marks thing, no? Fine. So electrogram, basically it measures the potential difference between the cornea and the Bruch's membrane. Normally it's 5 millivolts because eye is a closed structure with so much of electrical activity happening inside, because of which it will have some resting membrane potential. That's what we are measuring. That's what EOG is all about that. So how do we do that? We give two targets to the patient. We fix two electrodes, one near the medial canthus, one near the lateral canthus. Okay, so and ask the patient to look once to the right side and once to the left side. The polarity changes, right? Because of the change in polarity, we get a waveform like this, which has got a dark trough and a light peak. Okay, and if you calculate the ratio, what is it called? Ardence ratio. Okay, so normal it is 2:1. If it's less than 1.7, it's abnormal. And whatever, how is this base resting membrane potential maintained, which is the layer which is responsible for this? Retinal pigment epithelium. Okay, so whatever the disease which affects retinal pigment epithelium in isolation will affect electrooculogram. Fine, coming to the case example, this was a 11-year-old male, blurring of vision was 6/9. The timer is not showing here, so you can stop me whenever it's complete. It's not showing here. So 6/9 vision, born out of consanguineous marriage. He had this kind of a lesion in the macula, some yellowish deposit, and this is the autofluorescence test, and this is the OCT. What is it? This is like a spotter. 9-year-old. It's not CSR. Yes, exactly. Best disease. Okay. So let's do ERG in this patient. Let's see what's going to happen. Look at the fulfilled ERG. Go by order. What did I tell? First, look at the dark adapted responses. It's normal. Combined response, normal. Light adapted response is also normal. Now look at the EOG. We were supposed to get a peak like this. It's not there. So this is classic of Best disease. A normal fulfilled ERG and an abnormal EOG. Why it happens? Because Best disease happens because of the mutation in a gene called bestrophin, which is localized to the retinal pigment epithelium. Once this gene is mutated, the retinal pigment epithelium cannot function normally. So EOG is from RPE. So that's how the EOG gets affected in Best. So this is the full family. The father was asymptomatic, but when you called for the screening, he did had some lesion. So whenever you diagnose this hereditary retinal diseases, you should always screen the family members. So this patient, we did a genetic testing, had heterozygous mutation in BEST1. So this is second one is a 10-year-old male born out of consanguineous marriage, 6/18 vision. This is the fundus photograph. So the yellowish lesion which you saw in previous photograph, which was limited to the macula, now we can see there is an extensive distribution beyond the macula. And FFA was also showing some leaks, staining and all that. I'll show the autofluorescence now, which clearly delineates the hyper autofluorescent vitelliform deposit. Last case you saw, it was there, some present only here. In fact, this was referred to me from UVR department. This patient was given multiple steroids, immunosuppressants, AC tap, antiviral, you name everything he had taken, because they thought this is kind of an inflammation. And OCT also looks like an inflammatory disease. This is a subretinal fluid also, and there is intraretinal fluid also. Last case, what was there? Only subretinal, right? This has got intraretinal also. Any guesses? If you answer this, not gold medal, some diamond medal you will get. Fine, anyway. So this is a case of autosomal recessive bestrophinopathy, which is a new entity. Okay, I'm showing you this because you may come across these kind of cases. You should not misdiagnose. The first case what I showed was a Best disease. That was a dominant Best disease, where only one gene was mutated. This is a recessive disease, where both the genes are mutated, because of which disease is relatively aggressive in these cases. Okay, fine. So look at the ERG in this case. There's a gross reduction in amplitude. And combined response also same thing. Even light adapted responses are affected. And EOG is almost now unrecordable because there is no functional bestrophin gene. So both EOG and ERG are abnormal. If only is one abnormal, that is dominant Best. If both are abnormal, it is recessive Best. And clinical features also accordingly will differ. So this was a 10-year-old female, 660 vision. So there is some atrophic macular changes. I know screen you can't make out clearly. Born out of consanguineous marriage. See the autofluorescence. Now we can make out the atrophy clearly, and there are multiple flex-like deposits. Excuse me. Fleck-like deposits over here. So what is the diagnosis and what's happening in the OCT? Outer retina is completely thinned out. Macular atrophy with multiple flecks. Spotter, this is easy. Someone told. It's a Stargardt's disease, yes. So we did ERG in this patient. So now look careful. These are the typical printouts what you get in exam. What has happened to dark adapted responses? The wave was supposed to start from here. It's starting from here. It's delayed. Look at the amplitude. Amplitude is also grossly reduced. Same thing is happening in the combined responses also. The wave was supposed to start from here. It's starting from here. Amplitude, instead of going till here, it's stopping here itself. Okay, so the rod component is affected. The combined component is also affected. Now look at the light adapted. The wave which was supposed to start here is starting here. So the latency is delayed. Amplitude is decreased. These are the only two things you need to look. The latency, that is the onset of waveform, amplitude, which is measured from trough of previous wave to peak of wave of interest. Okay, both are affected. So what does it indicate? You should just tell it indicates cone rod dysfunction. That's all. Diagnosis could be anything. So whenever you read an OCT, go by order, tell the findings, could be suggestive of so and so. You should always give it differentiated. Don't, I saw you people doing when sir showed on OCT, you suddenly told CSR. So don't do that. Whenever you been given an like imaging entity or anything investigator, go by order. So you will have an advantage. You will take a lot of time to answer. So you can avoid unnecessary question which you would not have read. And examiners will also be impressed when you go in a methodical order. So this has a cone rod dysfunction. So what is the use of doing ERG in Stargardt's? You must be asking, sir, it is a Stargardt's disease, there is no treatment. Why are you doing ERG? Because Stargardt's can be of three types. 1 minute. Depending on the component of receptors involved. If it's a full-filled ERG is normal, means the disease is limited to the macula, the chances of progression is nil. If only cone component is affected, there is 20% chance of progression. If both cones and rods are affected, as in our case, there is 80% chance of progression. In this way, in a way, we can prognosticate also. Okay, I'll just skip few case example. I'll be just outside in case if you want to have only 1 minute. Okay, this case had a photophobia. Fundus appeared normal. So there's a small cavitation over here. Can you see? So what could be the diagnosis? We can see these cases of photic retinopathy, laser Bunsald. Even that's what I thought. But when I did an ERG, look at this. Look at the dark adapted responses, completely normal. Look at the light adapted responses. It is undetectable. So the lesion is such a small lesion at the foveola, but the ERG is telling the cones in the entire retina are non-functional. So this is a case of achromatopsia. Sorry for the spelling mistake. So it is a type of stationary cone dystrophy. That means it's non-progressive one. Okay. Okay, so that's it. I think I'll have to end here. So always remember, so any investigative modality, don't take it in isolation. It has to be correlated with other imaging modality, as Giridhar sir was telling, and also the history and the clinical examination is very important. Okay, so all the best.
Thank you, Purna Chandra. Fantastic talk. Very clearly explained. This is not a topic that most people understand. And it just remains for me to thank all our speakers today for fantastic talks, very insightful talks. And also my co-chairs, Dr. Jatinder Singh and Dr. Purna Chandra, for helping me with this session. Thank you.